And people, I say this in the most love I can. Like sometimes you're just screwed by your genetics. Like Indians from India, highest heart disease, I think genetically. But like natives in the U.S. eating fry bread, that is the worst thing they can eat, and that's killing them. So people just don't know that there's some foods you may be worse off with. But meat, like I'm on the paleo train right now, but Mediterranean's great, vegan's great. As long as you cut out the sugar, people seem to respond pretty good. Hello, and welcome to Legends of Longevity with me, Joseph Entz. I'm your host, and I'm thrilled to have you join me on this journey towards living a longer, stronger, and more vibrant life. The podcast is about uncovering the secrets to longevity, things your doctor does not tell you, whether it's groundbreaking advancements in heart health, lifestyle tips to keep you thriving, or inspired stories of people who've defied the odds. Together, we'll explore the tools, techniques, and mindset shifts that can help you unlock your fullest potential. Whether you're here to learn how to enhance your well-being, support your loved ones, or just stay ahead of the curve in health and wellness, you're in the right place. Let's empower each other to not only live longer, but live stronger. Hello, everybody. Welcome to Legends of Longevity. I'm here with Dr. Neil. He's a board-certified family physician. He's been at the best medical schools, George Washington University School. He's written a book, The Longevity Equation. He's the CEO of the Institute for Human Optimization. He delivers precision medicine. He's a mind who reads a lot and integrates it into his practice. He holds molecular biology degrees and medical laboratory sciences from the School of Medicine, from the University of Central Florida. And he completed medical school with honors at Ross University. His research spans pharmacogenomics, nutrigenomics, and microbiome sciences. In short, he operates at the intersection of longevity, biology, and real-world clinical practice. And he's one of these doctors that is breaking out of the system. He's got cash programs that you can look at. And I got to tell you, sitting at the back of the room in the conferences with the people who invented the conferences or put them on, and we were talking about what's next. It was, longer living. It was healthier living. And then it got to functional medicine, and now it's at longevity medicine. And we were wondering what's next. And it seems to us that people paying for the service they want, for the knowledge they want, for the education they want to manage their body a little better. Doc here is one of the guys who does that. So welcome, Doc, to Legends of Longevity.
Thank you. Thank you so much for having me. How's everything on your end?
Saving lives, stamping out disease. That's what we do around here.
I know. I love the work that you're doing.
It's fascinating to me seeing the split in medicine, where the insurance model that does not do any prevention, does not optimize you, does not make you... Man, they'll bail you out in a pinch. If your heart's busted up and you're in the hospital, they do a pretty good job of patching you together. But there's no maintenance programs. And I'm happy to see what you're doing. I was looking at your website, and you're offering things that not many people offer. The programs you offer, proteogenomics, metabolomics, epigenomics, microbiome. Now, you're not calling these things different things. Like, past blood sugar and whatever, what's your bag in medicine? Because you've got some really decent-looking programs.
Well, so I think that's a very interesting question because it kind of has led me to where I am today. My undergrad, as you mentioned, was in molecular microbiology and medical laboratory science. Went to med school, and before I even started med school, I was already studying with some of very unique people in our space, from the Germans and Swiss, like Thomas Rau with the Paracelsus Clinic of Biological Medicine in Switzerland, Dr. Peter Diadamo, the naturopath who wrote Eat Right for Your Blood Type, and later on the genotype diet. So I went through and I studied all these different integrative modalities. I started working at a Whole Foods when I was 16 years old and learning the nutraceutical industry. So I considered myself almost like a self-taught naturopath prior to starting med school. Studied with the ABC, American Botanical Council, with Mark Rosenblum, or Rosenthal, and studied medical acupuncture at University of Miami, clinical homeopathy with CEDH, and all those integrative modalities, kind of in parallel or before starting medical school. And then you get into med school and you're like, oh, what's going on here? Very reductionist model, biopharmaceutically oriented, but very important depending on where you are in your health continuum. For once you cross that biological threshold and you need drugs or acute intervention, you need it. So modern allopathic medicine has its place, like you alluded to. God forbid something breaks, they could fix it, right? But how do we prevent things from breaking down, and the different modifiable factors that mediate that pathophysiology or slow decay? And that's why I like to do what I do, look upstream. What are those different factors that are influencing somebody's health trajectory? And one of the classes I teach at George Washington University, the omics of medicine, connecting those molecular dots from genome to phenome, gave rise to my clinical practice, where I just had a patient that just left here right before jumping on, and people get it. They're so disenchanted with the modern medical system right now. They have, no tools or resources to answer some of the chronic issues that are plaguing these individuals, whatever it may be. And I think that's why we need to be looking into these different longevity forward kind of technologies and therapeutic interventions to basically remove those obstacles to cure. Furthermore, that's kind of what gave me inspiration to form the American Board of Precision Medicine. And the American Board of Precision Medicine is basically kind of, taking a evidence-based molecular approach to precision health. And how do we connect those dots from genome to phenome? And so that's what I do and profess within the board. That's what I do and profess within my clinical practice and at the university. So unfortunately, how do we get modern healthcare, who doesn't want to pay for labs to begin with, to adopt and democratize, this unique molecular profiling of somebody? And I think industry is going to be leading that charge. If you're to look at Illumina is the company that basically makes all the DNA testing machines that are used in labs and research centers. They have a new CEO, and the new CEO agrees that the future of healthcare is going to be multi-omic profiling. And I think, and for the audience that doesn't know what that necessarily means, it's looking at the respected science of each kind of molecular layer. So the central dogma of biology is, DNA and RNA, RNA to protein, right? So that's genomics, transcriptomics, and proteomics. Well, that is looking at transcription and translation, mediating that bridge from DNA and RNA to protein. And furthermore, what does the exposome tell us? We're all doing some level of, within our network, that is, Joe, some level. So the exposome is the environmental exposures on that we're. So so epigenetics refers to histone modification and methylation and some of those other kind of factors that influence the upregulation or downregulation of very specific gene expression, right? So it's kind of the environmental impact on gene expression, where the exposome is almost like environmental medicine, where you're measuring all the different crap that we're exposed to: heavy metals, phthalates, parabens, organophosphates, microplastics, forever chemicals, PFAS, all that stuff, right? So we need to measure it, right? And if we're eating or breathing or inhaling something that's bad on a regular basis, it has a potential of bioaccumulating in our system. And if our genetics are kind of screwed up to begin with and impaired, and we don't have the genetic resiliency needed to biotransform, detox, or metabolize, excrete those things, then we're ultra screwed, right? And because those environmental things now could lead to metabolites that lead to DNA damage, and that DNA damage perpetuates, and that's where cancer could set in and develop.
Right. I'm thinking about all those guys with horrible jobs where they're breathing in fumes. They're in moldy buildings and they get home and they're just destroyed and they don't know.
occupational exposure is the biggest source of a lot of the exposomic, things. Not to mention, like you said, moldy homes and all sorts of the utensils and the cooking materials and all the PFAS and the microplastics and all the crazy crap that we see. And I measure that stuff, right? I measure the DNA, I measure the transcriptome in my really sick patients. I measure the proteome with advanced biomarker analysis. I measure the metabolome. I measure the exposome. I measure the epigenome through cancer and biological age profiling. So I put all that together to make sense. Now, this isn't for everybody, right? And I tell my patients, look, if you're coming to me, I don't want to be another doctor, right? And there's enough of those insurance-based regular doctors that are doing routine things. I'm your health intelligence partner. I'm going to take that deeper dive, and we're going to connect those dots, and we're going to make sure that there's a therapeutic order that we can follow that's going to make sense. Across the hall from me is what I call longevity gyms. Longevity Gyms is basically a center with all the best technologies that you could imagine. I've got hyperbaric oxygen, whole body photobiomodulation, pulse electromagnetic field, intermittent hypoxic and hyperoxic therapy, contrast therapy, all sorts of things right across the hall, right? And we are using that in a very structured therapeutic order, right? Because you don't want to go, if somebody's has a ton of inflammaging in their system and mitochondria is insulted and, they're exhibiting cell danger response, you don't go in there and throw photobiomodulation into the mix. You don't go and perpetuate a shitty mitochondria. You got to pull out all the bad stuff first, right? And stimulate mitophagy, right? And cell recycling and other micro autophagy. Because again, we could get into the whole thing with longevity. What is longevity medicine, right? And when you start looking at these different modalities, I mentioned to you all the integrative modalities that I studied when I was in undergrad. TCM, Ayurveda, homeopathy, botanicals, and then you go up the layer of, okay, what's functional medicine? Well, functional medicine is very root cause analysis, timeline, matrix, looking at all those different ATMs, antecedents, triggers, and mediators. Well, what is longevity medicine? Well, longevity medicine is an additional layer where you have different therapeutic interventions, and you're looking at things using the hallmarks of aging. The 12 hallmarks of aging: genetic instability, telomere attrition, loss of proteostasis, decreased nutrient sensing, epigenetic alteration. I always like to quiz myself on this. Dysbiosis, chronic inflammation, cellular senescence, stem cell exhaustion, decreased macro and microautophagy, all those different molecular mechanisms. And then what is precision medicine? Well, precision medicine now is using those molecular layers, like I said, multi-omic profiling, systems biology, network analysis, to further quantify this on that level. So that's how my crazy brain thinks of connecting all those modalities. And I've studied these modalities since I was a teenager inside and out. So, when I was 19, I bought this microscope right here, and I started analyzing everybody's blood, and I thought I wanted to be a hematopathologist until I worked with them at MD Anderson Cancer Center in Orlando, Florida, and realized that was not for me. I'm too much of I like the hands-on stuff. I like some procedures. I like to hang out with people. I enjoy looking under the microscope, but I also enjoy speaking to, my patients in general. So, yeah, that's how.
Dude, you're the reason the system's breaking. And just so everybody understands, I do heart disease, my testing is for heart disease, and people new to it will say, well, you must work with a lot of cardiologists. And I'm like, well, that's not the way the system works. If you go to a cardiology office, and let's say there's 10 doctors there, 10 cardiologists, they just do what they do. They check your heart for electricity, the electricians, then the other cardiologist checks you for plumbing, making sure there's no, but they don't really give you the pep talk on prevention or how to avoid coming back here. You're almost on a treadmill until they need to do surgery or something, or you're doing your yearly visits. If you're lucky, there's a nurse practitioner in that office, and she's passionate about cardiovascular disease, and she'll meet with you and talk you through your diet and your exercise and make sure that but that's not in the system. There's no reimbursement for prevention. There's no reimbursement. So people thinking that I work with no, my man. I work with passionate doctors who've been playing with this stuff since they were a kid, who are the nerds who buy a freaking microscope because that's what speaks to them. And they have preconceived conditions or ideas before they go into med school. They know that they're getting fed a pretty narrow line, a pharmaceutical line. And now you've got friggin' bariatric, you got pressurized chambers in your, like, you're breaking down silos of information. There's interdisciplinary play that can help some patients in terrific fashion, like rise and walk healing. And I bet you get a lot of patients that just don't know how to solve their problem, and you ease them out of it.
My the last patient that was just here and just left the office, she's been to name a specialist, any specialist, neurologist, cardiologist. She has multi-system, multi-symptom inflammation, and it's coming from her environment. Now, we haven't done the testing as yet because this was our initial appointment. I did peek at her blood under the microscope and found some unique morphologies that kind of tie into the cardiometabolic discussion. Because under the microscope we could see hypercoagulation, fibrin networks, the need for nattokinase. I know you love to eat your fermented stinky nattokinase, right? And we see platelet aggregation, we see anesicytosis, we see the end result of impaired methylation and MTHFR with the manifestation of platelet aggregation and little hypercoagulation within the system. And homocysteines manifestation. So you see all that microscopically, and you could go upstream and connect those dots on the genetic level and see the different polymorphisms influencing, those kind of those different imbalances on a proteomic level and on a cellular level. So it's very interesting matching the peripheral blood morphology to the genetic testing. But the reality is, this person is suffering. And she's been to all these ologists, ophthalmologists, neurologists, cardiologists, gastroenterologists, and they don't know, they don't communicate, right? And everything is in its silos. But, ultimately, I think, from a pathophysiology perspective, there's four main things that are happening, shifts in the system. And it's inflammation, oxidation, ischemia, and immune dysregulation, right? And cardiovascularly, right? So if we just want to use that in the context of what we do with Vaso Labs, right? Looking at carotid intimal media thickness, which is a kind of a example of the larger vascular dynamics of what's happening on a microangiopathic level. It's basically, think about what oxidized LDL does. Think about what ischemia does, right? Low oxygen. Think about what, the role of nitric oxide in all of this, the glycocalyx. Think about what, immune dysregulation with foam cell activity does, right? So inflammation, oxidation, ischemia, and immune dysregulation are the four main perturbations in the homeodynamics that lead to name a disease process, any disease process. We just linked it to vasolabs, but we could link it to Alzheimer's. We could link it to, gastrointestinal issues. All of those things are the primary drivers of disease processes, right? And on a proteomic level, when we're measuring advanced biomarkers, you see that stuff, right? And it's not always a C-reactive protein or ESR. There are other biomarkers that indicate, inflammaging in the system beyond those traditional, biomarkers that everybody likes to go to.
All right. A couple questions. You have a biomat in the other room, you said. And grounding. A lot of people are interested in grounding, and they see their blood spread out, like there's no clumping like you talked about. Is that real?
So I have a patient that did research at the NIH and did all the publications around grounding. And, I was never really that skeptic of it, but I didn't know there was research and evidence to support it, and there was, it was done by the NIH, and this guy actually sent me a welcome kit, he sent me the mattress cover and the pillowcase cover, and then the books and a bunch of other really cool stuff for the grounding. And furthermore, if you were to look at like the Germans and Swiss, right, and the Austrian, I would say the Austrians are way ahead when it comes down to grounding and harmonizing the home. There's a company called GeoVital out of Austria where it's like you get the little EMF detector, right, and you walk around your home, you see the hot spots, and you don't sleep near it, right? You turn off the Wi-Fi and all that other stuff. In regards to those using this form of microscopy to just show you the before and after of like grounding, I'm always very skeptical of that because there's ways to manipulate the slide. Again, my degrees were in molecular microbiology and medical laboratory science. So I got the integrative with the conventional, for the hematopathology. And I think there's a lot of bullshit out there when people are trying to sell you something strictly using that live blood cell analysis. Because I could tell you I could be in this part of the slide and it's all effed up, and then I could go to another part of the slide and it's beautifully dispersed. The way you
Oh, it's not homogeneous.
Yeah. So there's ways to manipulate it that I just don't trust these people trying to sell you shit based on that form of testing, right? So I love this technique, and again, it brought me to study with the Europeans because there's a whole system called German New Medicine that leans into this, and there's a whole system of medicine called isopathic medicine that looks at using this technology. And I can't even begin to tell you, to basically look at the peripheral blood, get a better understanding of what's going on, and really link it to some deep, deep clinical associations.
All right, so let's rank it. Walking around barefoot in the grass. Good on a scale of 1 to 10.
Oh yeah, of course. Yeah, good.
All right, how about grounding my bed sheets?
I love it, man. I'm telling you, it made a huge difference in my HRV since doing that. So I would say, that's a solid for me. As
All right. And then a biomat or an electric blanket or something that's supposed to.
So I would be careful. There are different technologies out there that have smog within those biomats, right? And there are some that are not good, right? I know there's that whole superhuman protocol that recommends, Gary Brecka and the Da Vinci Labs and, Dana White are endorsing. However, I question that biomat that they're using in that protocol. I don't want to say anything inflammatory or whatever. I just question it, maybe. Let's just say that. You just want to make sure there's no electrosmog associated with some of those mats. That's my 2 cents. Yeah.
Fascinating. Fascinating. And I always love when I hear people are like, I played with this when I was a kid. I went into an adjacent industry and my knowledge base is a lot different than what's out there. And that seems to be what you're telling us. And I wish that happened more. Like, I donate my old ultrasound machines to the local high school because kids playing with this stuff, you get those ideas percolating all through college. You get much higher quality ideas out of these kids. Super disappointed the school system doesn't do that more.
No, you need the hands-on, man. It was interesting because I got introduced to this microscopy technique when I was in high school. My high school wrestling coach, right, was like, "Hey, I know you work at Whole Foods and you sell supplements. Have you ever seen nutritional microscopy?" And that's how it was presented to me. And I'm like, "Oh, large red blood cells are associated with folic acid and B12 deficiency. Wow, iron is needed in small red blood cells. Wow. Certain amino acids for white blood cells that look like shit and are shattered. Wow. Oh man, nattokinase for fibrinolytic activity. Oh, that's cool, right? Oh, the cells are spiky. That's lipid peroxidation and membrane, free radical damage, and you need antioxidants and astaxanthin, vitamin E. Wow. So seeing those nutritional associations in peripheral blood morphology was really cool, right? But then I took it to like a whole nother degree. I could teach, classes on this at a university if I wanted to. It's just the associations. And then you got all these people that are trying to do it, and they there's some charlatans out there that are like strictly nutraceutical sales based on it. But I don't want to shit on them too much, but there's a lot of bullshit out there, unfortunately.
Dude, I gravitate to the people who have passion behind their curiosity. And like your knowledge base is so much more well-rounded because you got to play with it. You got to see the interaction. And it gives you as a physician levers to push on your patients.
Oh yeah, yeah. I look, when I show them their blood, they're like, "Holy shit! Why is that look bad? What are those black lines? What are these? You know?" And it's you're able to show them what's really going on. You know, it's very interesting. It's a motivational tool. I use it strictly for research and education. Right? I don't diagnose, treat, or prescribe based on that. It's that's my little you know
You'll get this email soon, but I talk about the VIP Visa study where they scanned 1,000 people. They brought them to a table and said, "Here's healthy arteries," and they showed some images. "Here's nasty old man arteries, and here's yours." And the patient sitting in that energy, the nurse talking to him didn't justify it. "You're okay. It's not so bad." No, they let him sit, and they saw that plaque in their arteries, and the patient made much better decisions to the tune of reducing their risk of heart attack and stroke by 50%. And you explaining that to your patients, like I could never, if I saw my blood in a nasty way and I believed it, I could go not eating another Dorito again or taquito or any of these Frankenstein foods.
Oh yeah, yeah, that's exactly it. It's a motivating tool, and I gotta say, look, for certain folks, including myself, heart disease is there's a lot of genetics tied into it, right? I'm a walking cardiometabolic mess, historically, and despite exercising and training jujitsu multiple times a week and wrestling in high school and lifting weights and all the other stuff, my genes unfortunately are Southeast Asian. I'm Indian as crap, and we're prone to heart you know so apob high, lp little a high, ldl high, and I got that on my dad's side. When looking at the difference in lp little a alone, my mom doesn't have elevations there, but my dad does, and he had stenting done when he was like in his I pushed him to do a cac in late 50s, right? And thank goodness he did it, because there was, he had 95% occlusion at LAD, asymptomatic. And if we didn't do the CAC, right, and what he could have a MACE, a major adverse cardiac event.
95% occluded, and he felt fine. Wow. On the Widowmaker.
So, and I'm telling you, and I've had very unique, history cardiovascularly as well, because I've been tracking my plaque since I was in my 30s. I'm not like I was statin adverse. I'm on Repatha right now, personally. Um,
I've seen incredible things on Repatha.
Repatha is fantastic. I love this medication, but getting qualified for it through insurance is a pain in the ass, right? And I've actually had a case of what's called walk through angina, right? Where I could I basically would get on the jujitsu mat, and I would be the first 5 minutes of warming up. I'll be like, all right, we're doing our exercises, whether it's cartwheels, rolls, pummeling, whatever it is. I feel fine. I just always associate, I just got to warm up, right? And once I'm warmed up, I could roll for an hour, no issues. And rolling, like fighting, jujitsu, grappling for an hour, no issues, right? And that was a very atypical presentation for severe heart. I have severe heart disease, right? And I thought, I've taken my supplements. Again, I was, I'm on Repatha now, and I'm chewing on, these guys, and I've got my glycocalyx stuff. I'm measuring my nitric oxide levels and all that good stuff, and but yeah, sometimes it escapes us. My diet's pretty good, but I'm a bad Indian. I love my meat. I love my meat. I feel better with meat versus anything else. Um, so yeah, it's just one of those things.
Yeah. And people, I say this in the most love I can, like sometimes you're just screwed by your genetics. Like Indians from India, highest heart disease, I think genetically. But like natives in the US eating fry bread, that is the worst thing they can eat, and that's killing them. So people just don't know that there's some foods you may be worse off with. But meat, like I'm on the paleo train right now, but Mediterranean's great, vegan's great. As long as you cut out the sugar, people seem to respond pretty good.
I agree with that. And you got to measure like those additional biomarkers, LPPLA2, ApoB, TMAO, LP little a, particle size, okay, sure, whatever, but everybody has, I shouldn't say everybody, but the majority of everybody has, particles that are reflective of atherogenesis. But when it's, when you start really getting into the genetics of it and the other biomarkers associated with it, the trifecta in my book that I've seen historically is LDL, especially oxidized, homocysteine that might be running high in the context of high ApoB and LP little a, right? And LP little a is a little bit less impactful if ApoB is normal comparatively. But again, look at what's going on. Have you heard of the MESA study?
I'm not recalling it. I heard the name though.
So the MESA study, I think, is one of the more modern day Framingham kind of research studies that's looking at multi-ethnic study of atherosclerosis. And they're also infusing coronary artery calcium scores into it, and looking at just the variances across different ethnicities, because Framingham was primarily Anglo-Saxons in the Northeast. And so, very homogenous, and, didn't have the biodiversity needed to capture true interventions. And this is a classic kind of concept of precision medicine, breaking down those silos and looking at the different variables that influence somebody's pathophenotype. And what we're going to realize is that the taxonomy of disease, everybody's molecular signature of disease is going to be different. Our conceptual framework around diseases and what we call diabetes or Alzheimer's or heart disease is all going to have a different kind of signature once we start deep molecular phenotyping of individuals. We're going to find that their environmental exposures, their inflammatory burdens, the microbiome is totally different. Their genetics are different. So everybody's disease, what we characterize as disease today and the pill for that ill, is going to be so different once modern medicine starts leaning into precision medicine as a tool to better characterize this. Now, granted, we could use this for better drug discovery and try to identify more targeted interventions that are suitable based on some of these molecular profiles. That's more to come on that, with drug discovery and, and I think these different peptides, short protein molecules. Look at GLPs. Holy shit, has that like revolutionized, a lot of, stuff here in the US. But there's so many other peptides that are out there that have tremendous therapeutic benefits, and just aren't, incentivized by big pharma to research because they're off patent. Right. So if it's a patent they're worried about, hey, go throw some albumin on that molecule, trademark it, and do the research so we could get these commercially available. Because peptide therapy, I think, is going to be very important in the future. SS31 just got approved, for a mitochondrialopathy recently, and we're seeing these peptides being kind of emerging in our field, especially in longevity-based practices. Right.
All right, for the audience, peptides or amino acids, are they 50 or less, 60 or less?
Yeah, I thought there was like 46 or something or less or whatever.
Yeah, smaller chains of amino acids that are naturally found in the body, and this whole industry starting of making these, giving them to people, and they're calling them things like the Wolverine protocol, and there's tons of them for losing weight. GLP-1s are like they're amazing. The problem is they're such short chains and they're already found in the body. They're hard to patent, but the FDA and the industry is making moves to take them off the market or control them because they seem very productive, very useful.
That's correct.
And so we're talking about peptides. I mean, there's a whole universe of them. Nobody's quite sure if they've got super high quality peptides. Everyone says they're out of China. There's a few out of Europe. They're kind of tricky to source, but there's amazing things like people saying they did a miracle healings and injuries from 3 years ago. They're finally getting the nerve damage coming back to their hands. Amazing things. But you're going to go to a doctor who learned about it out of a book or went to a 3-day conference. And some people are uneasy with that, but the hype is pretty real on them.
Yeah, yeah. No, they're interesting. The problem is there's a lot of bro science out there, and the bro science could get you in trouble, right? So just jumping on CJC or Promorelin or Sermorelin or, any of those kind of growth hormone analogs is just like, don't do that, right? Because, make sure, you're up to date with your USPSTF screening guidelines of cancer, right? And go beyond that, look at, additional tests, maybe, to identify any lesions somewhere, because God forbid you just start doing it because you want to get shredded or recover or whatever, and then you got a tumor. Not good, right? That's a real potential, right? So, same thing, like BPC 157. Love the peptide, right? I use it clinically in very specific and controlled situations. But think about what you're doing, all right? You're stimulating fibroblast cell activity, which is going to cause growth and healing, which is great acutely if needed, right? And then also, what are you doing? You're stimulating VEGF, vascular endothelial growth factor. What's that do? Angiogenesis. What could that do? Feed a tumor, right? So you got to be smart with, some of this stuff. And I have people that are coming to me for, because, I'm knowledgeable about stuff, right? And they're like, oh, I listen to this podcast and this influencer, and I've been on, this peptide stack for a very long time. And holy shit, that's not good, man. You gotta, that's not right, And then there's a seasonality to it as well, with certain peptides. Like if you're going growth hormone, like our growth hormone naturally declines by like 35% during the winter. And that's not the time to be in an anabolic state, It's so these is the chronobiology of it. There's a chronobiome associated with the I think they call it chronopharmacology, looking at the circadian rhythms of certain things, So there are ways of doing things, right, that should be matching nature and, seasonal biology as well.
Oh, whatever. Like I can do a cold plunge. I won't even turn my shower to slightly cold. I know the benefits. I want to do it, but a cold plunge to spark these. Yeah, I'm picking up what you're laying down, and you're absolutely right. How come not everybody just gets pre-methylated B vitamins? Because there's a lot of genetic tests, and a lot of people are finding out they can take certain vitamins, but their body can't make use of them. So they get them pre-methylated, is what they call it. What's your thoughts on that?
So if you're referring to like methylcobalamin versus cyanocobalamin or hydroxycobalamin, you got to be careful with methyl donors, right? Because the dark side of the methylation equation is the upregulation of dimethyltransferase type 1, right? Which goes in there and could potentially lead to a loss of tumor suppressor activity, aka cancer. So all these people are like, oh, you got to take a what methyl some shit whatever and do this every day. No. Be careful. Be careful. Get natural methyl donors wherever you can. Green leafy vegetables and all that good stuff. Stay natural, right? Because when you go in there and hypermethylate, that dimethyltransferase type 1 activity isn't, you don't want to modulate that towards the wrong direction, right? Because that's not good. So there's a lot of influencers out there talking about, the methylation thing is so like 10 years ago, 15 years ago, but it's been revisited by certain folks in the space, and it's been rebranded for the use of nutraceutical sales and all this other stuff. I'm not saying, hey, don't methylate, dude. Get your genetic profile, understand where the hell you are with that, and be smart with your methylation. Because another thing is, when you go in there and you precipitate hypermethylation, you can actually precipitate, like neurotransmitter excitotoxicity that could lead to schizophrenia or something bad, right? So a lot of people their anxiety will get worse, their depression will get worse, their cognition will get worse because they're not doing it right. So there's a fine line with methylation.
That's fascinating.
Did I answer your...
I think so. Yeah. You got to be careful with that stuff.
Everything needs to be in balance. And just because you have a the first rule of genomic medicine, don't treat the gene. Don't. Right? Look for other clinical surrogates to identify whether or not it's being expressed. Do you know how many freaking times I have somebody with MTHFR or ApoB or LP little a, ApoE4, whatever it is, right? And their homocysteine is normal, cholesterol is normal, the lipid profile is normal, right? They might have glutathione peroxidase or reductase polymorphisms in their blueprint. And guess what? We measure certain things. Their membrane lipid peroxidation is normal. Their 8-OHDG is normal. Their glutathione status is normal. Everything is good. So don't treat the gene, right? Go upstream. Use genetics to basically guide where to peek under the hood, right? So, I think there's a misnomer, and the role of genetics in medicine has been hijacked by people that aren't trained appropriately, and they're trying to sell you some shit, right? And that's not good. And once you have that breach of integrity, once there is a commercial self-fulfilling interest, you got to be careful and question everything that they say. They might have the right sound bites, and they might quote the right study, right? But you need not an influencer to save you, but a really well informed functional or precision medicine physician that knows their shit, right? And knows how to look at things. Because all these people, you're on Instagram, we're all on Instagram, and all that other stuff, and the amount of dog shit I see online, right, is just insane, man. Insane, you know?
So much baloney out there.
Yeah, sorry I curse a lot.
No, I love it. I love it. I'm from Boston. I now live in Utah, and I gotta watch it.
You do.
Okay, I did want to state. You said something a few minutes ago. The biomarkers that you like. I will tell you that independently, before I knew a lot about LP little a, when I noticed there was plaque on both sides of the patient's neck, I would tell the doc, check their LP little a, because that's pretty closely. It's usually high when there's plaque on both sides. And then you telling me about the ApoB, like ApoA, like those patterns affect the LP little a. Sorry, you got me thinking about that a little bit, because I didn't realize they were chained together somehow.
Yeah, there are studies on that looking at, those with ApoB and LP little a, and those with just LP little a, and those with just ApoB, and the atherogenic potential comparatively. But the thing is, man, these clinical studies, I'm going to say you could try your best to do this, and I'm just saying the future of research is going to need to lean into more of a precision-based model. I appreciate the method that's being used to validate a hypothesis, but the problem is when you're studying humans, man, there's so many different factors that influence what's going on. And that's why I think for future clinical research trials, we need multi-omic profiling before people are enrolled in these studies, because the things below the surface, even trauma, man, crazy things like trauma, PTSD and trauma, right? There's a gene called FKPB5, right? This is known as a PTSD gene, right? What happens when somebody's got trauma? You're locked into a state of sympathetic dominancy, right? You could take all the, the stuff you want, and if you got this thing that's, plaguing you, and this could even be transgenerational epigenetic programming, through generational trauma from years ago. I've seen this, like especially those, that come from, a bad past, let's say, right? Another analogy would be the thrifty genotype, where there was famine and basically, in
Holodomor. The Holodomor, and was it the Ukraine in the 1900s? They didn't feed them, and you could see their pattern repeating over generations because the parents starved once. Yeah, I'm picking up what you're laying down.
Right. So there's a lot of different interesting associations there, right? And I think, if you're not doing multi-omic profiling on your patient, because what if they're vitamin D deficient? What if they're omega-3 deficient? What if they're, exposed to a high amount of mercury, lead, aluminum, tin, whatever it is, arsenic or whatever, right? How's that going to influence their clinical response to intervention and therapy if you're not addressing the exposome? What if, they are genetically jacked and they're, from a pharmacogenetic perspective, they're slow metabolizers or ultra rapid metabolizers. All of those variables on an N of 1 basis influences somebody's receptivity to intervention. So,
How do you not deal with testing buildup? because right now most doctors can only handle so much information with their patient. They don't really build a deep bag of tools. Like you're listing off genes and therapies. It's just easier for you than most other doctors, and I'm bless you for it because people need that knowledge. But most docs, their bench is not that deep, and man, it just feels like they're not even trying half the time. But your interdisciplinary approach here, where you followed your curiosity and your narrative kind of clicked together. I've seen the blood in these different states. I've seen these patients in these different states. And then you've got a lot more to work with. Insurance doesn't pay for that. So that makes you different.
Well, the thing is, I'm trying to democratize this, so this will become the norm in the future, because again, I think industry is going to be pushing it. Because if you were to look at the trend in the research publications, you are seeing the constant utilization of multi-omic profiles to capture these different molecular signatures, right? And I think what needs to happen is that translational process, not from RNA to protein, translational process in medicine where we're bridging the gap from bench to bedside, right? And the thing is, we have commercially available segments of these different forms of tests, right? And it's like, okay, are you going to go back to med school and learn genetics? And there's a difference, between genetics and genomics. Genetics is your classical Mendelian genetics, inborn errors of metabolism, your PKU, cystic fibrosis, and those more obscure diseases. Versus, hey, how do we use your entire genome to kind of navigate your instruction manual, peek under the hood of the car, of the machine, to pay attention to specific vulnerabilities, right? How do we use that information in a precise way to look upstream proteomically to measure if there are any deficits in those areas, clinical manifestations. And then how do you link that to the environment, right? Because there's a lot of folks in the research world that's saying the genome is dead, right? Outside of genetic engineering and CRISPR, there's not, it's hard fix, right? So what do you do? Well, that's the epigenetic potential, right? You're, through lifestyle and diet and all that other good stuff. But then it's also looking at the actual exposome. And, I'm a part of the Human Exposome Project that recently launched with NIH and Hopkins and Columbia University. And essentially, I'm like I was on stage with, some of the guys from NIH, and nobody could say, hey, this is how you measure the human exposome, right? And if you measure it, how do you get all that bad stuff out of your system to begin with, right? What does a detox protocol look like? How do you enhance biotransformation? You speak to a toxicologist, and they're going to say, no, that's detoxing is not real, right? It's just weird, man, the world we live in when it comes down to science, research, clinical application, and literature, because you got all these PhDs saying something. But have you ever touched a person? Like, outside of a rat? I know you probably, studied some rats and you may have killed them, you sit, for the name of science. But, when you're speaking to somebody and you're hearing their story, and you see the suffering in their eyes, and you get that emotional connection, you got to do something about it, right? And you got to, and protocols aren't standardized. You could use segments of like a protocol to like adopt it to that person, but everybody's therapeutic order is going to be different in regards to unlocking their healing mechanisms.
Wow. It sounds, doing it right sounds so complicated. And I know computers are going to be pulling together the knowledge base that you've put together.
Well, precision medicine is going to be AI first, right? There's no way that the human brain could computate all those different signals and inputs, right?
Yeah, I was at a medical conference for Fountain Life, and their AI dude got up and he said, here's your cell phone. On it, you've got your medical records. Everybody's like, oh, that's cool. We kind of expect that now. We created our own custom AI and we put it in the program so you can ask any question you want. You can say, please look at my blood labs and my genetic code and actually do it my epigenetic, what levers I can push and give me a diet and exercise plan for the next 3 weeks, keeping mind of my sleeping patterns. And it'll do it. And the AI is getting better and better. There's still some misses, but you can ask very specific questions that no doctor could answer.
Oh yeah, I agree.
And we're getting there.
We are. I agree. And but then I love Fountain Life's model. I consider, they are very heavily backed and funded, and I've been to their center in Lake Nona in Orlando, and I know some of the docs there, and I know enough to say, hey, they're leading the forefront of this model, but it's still a $20,000 program, or $13,900, depending if you just do a one-time analysis, right? How do we bring the cost of that down so that everybody could get access to this kind of profiling, and what really moves a needle, for these folks, right? And it's good. A lot of it's going to be therapies, and what those therapies are could vary depending on what they need, and so that's a whole nother philosophical conversation. But I like their model. I like Human Longevity Inc. I don't know if you've seen HLI, but that was kind of the original Fountain Life with Craig Venter. They so much money and funding. I've been to their headquarters in San Diego and toured their facility. It's beautiful. They're doing a lot of radiographic imaging, advanced, heart analysis with the AI scan on top of full body MRIs and, CIMTs and all the wonderful imaging tools. But again, I think these models are all very unique. And what I've tried to do is synthesize the best in diagnostics, radiographic imaging, and everything like a Fountain Life or a HLI, and stack it with the best of functional medicine, and intervention, and then not to mention longevity gyms across the hall with some of those therapeutic applications. And I think that this is going to be the practice of the future.
I think you're onto it because like clinics like Humanot are popping up around the country where patients can go in, ask a doctor the questions they want, get the service they want, and they got 20 or 30 gizmos around the office that may help you out real specific. And they're at cash pay. Yeah, people want to feel better, live better, get the answers they need, and not just be given a prescription after 10 minutes.
Yep, Humanot, Jizen, another one out in San Francisco with Beth McDougall. That's another beautiful practice, and they all have heavy seed funding. I've tried my best to basically do that and self-fund it. Right, I've walked away from a couple VC guys trying to whatever and whatnot. I'd rather just be in my own little corner here, having fun with my people and giving really quality care to when people come and see me, I think a lot of my patients will attest to this. It's not a normal doctor-patient relationship. I want this to be your home. I want to have a friendship with my patients. I want them to have my cell phone number and reach out if they need anything and not abuse. I want them.
Right.
And that
bring back the healers, the relationship with you. Who cares about you?
I'm not a volume-centric practice, and I spend half my time dedicated to building the American Board of Precision Medicine, and we'll be scaling down the clinical side so I can focus on building the board to be at the forefront of the future of healthcare as we form more academic ties and affiliations, and we break down these silos so that we could, lead medicine into next generation.
How big is the precision medicine group?
The Board of Precision Medicine.
Yeah.
So we actually have our first conference December 5th at Arizona State University in association with their School of Medicine. And so that's our first event. And then we have another event coming up next year. We haven't finalized a date at the Buck Institute. And as you know, Buck Institute is kind of the pinnacle for biological aging research. And so we're just putting it all together. We're finalizing, again, this the evolution, the founder story of the American Board of Precision Medicine was this. I basically teach that multi-omic class at George Washington University. I went to University of Pennsylvania for a conference in precision medicine on multi-omics. And there I saw all these amazing speakers from all the Ivy League schools, Harvard, Hopkins, Yale, Mayo, and everywhere else in between, Stanford and so forth. And I realized, oh no, they're falling into the same trap. Your research is not going to make it to the bedside, right? And unfortunately, it was getting locked into that biopharmaceutical model again versus clinical applications in precision health. And then we've recruited to be our director of systems biology, Dr. Lee Hood. Dr. Lee Hood is arguably a visionary leader in the space. He's in his 80s and Caltech trained, MD, PhD, that started a bunch of different companies, and his most recent one is called Phenome Health. And Phenome Health is, again, doing a lot of this deep molecular phenotyping. And he also was part of Aravel, the organization Aravel that came out a couple of years ago. And long story short, recruited the right folks. I went to the UPenn conference, came home and realized there's a board of everything. Pain medicine, obesity medicine, lifestyle medicine, right? That are legit boards with MDs and DOs, but there's no board of precision medicine. So went out, incorporated a 501(c) in Delaware, the American Board of Precision Medicine, trademarked our IP, and I've just been in rapid recruitment phase of doctors from around the country and their subspecialties that I would like to align with our organizational mission and initiative. Now we're pre-seed and pre-revenue. I've spoken to all these very affluent people, and they're all saying the same thing. Create a for-profit arm so we could invest into it, right? There's no money in a nonprofit. But the problem is ethics become challenged, right? And I'm a very ethical person. I don't want our North Star to be corrupted or financially motivated, and our research and literature to be compromised or whatever it is. I want to lead with integrity with everything we do. So right now it's strictly on a volunteer basis, with our speakers, our lecturers, and our educators. Our curriculum is centered around multi-omic profiling, systems biology, and network analysis, connecting those molecular dots into meaningful translational applications for highly personalized medicine. And then there's a second vertical, which is of education, which is just centered around precision oncology, which is one of the greatest case examples of precision medicine. So if you were to enter the precision medicine world, you're going to see two main clinical applications. It's cancer and pharmacogenetics, right? And those are the two greatest applications. There's some other spin-offs, and some people will argue, and I agree. But what is a precision health narrative, right? How do we use this from a P4 medicine model, predictive, personalized, preventative, and participatory, so we could use this in routine primary care so that your internist or your family doc could start thinking and working along that alignment of maybe a longevity forward practice. Because if you're not doing longevity medicine, right, this is going to be the medicine of the future, right? And I know there's all these different networks internationally and nationally that are professing this, and I teach for A4M, part of their faculty for, I teach on the modules for longevity medicine. I might see you there again. I think we first crossed paths a couple of years ago, at A4M, getting my vaso labs and everything else. Yeah.
Dude, well done. Blazing new trails, helping new people. I hope the patients who need precision medicine find you. And that's one of the tough parts. They got to hurt enough to get on the internet and find a doctor who's not standard. And in this podcast, it's fascinating to me how many people work with research, and they'll tell me things like, "Oh, these research studies were ended early because they weren't as effective." Like this one in particular was a fasting mimicking diet, eating those cardboard boxes of food that last a week. And they found out the Mediterranean outperformed it, so they killed the research study. And you and I hear stories like this all the time. So yeah, we're a little distrustful of the pharma narratives. When the reps come, they're all speaking facts, but they're not the complete truth. And so the whole statin narrative, the whole lipid cholesterol narrative is questioned by a lot of people now, because since the 80s we were told you're at higher risk, but certain research studies come out saying that's not exactly true. Half the people in the emergency room have normal cholesterol. So they got a heart attack, they're in the ER, like, what's up with that? Cholesterol didn't catch those guys. And then the people who live to be over 200 years old or 100 years old, all their cholesterol is high, over 250. You read a little more and you find out, well, your cholesterol does turn into vitamin D3. Your body needs it for all these other functions. It might not be the best thing to just clobber all your cholesterol. What are your thoughts on that? And then we can start wrapping up, because that's a question I have, and I hear from a lot of people. And the docs I just say the cholesterol narrative is falling apart. They nod their head because there's some holes in it, but nobody's got a complete new narrative to work with.
It's interesting because I have a lot of LDL deniers in my practice, right? I write a fine line. I've said, okay, you can't look at LDL in isolation. You need to look at it in the context of, is it oxidized? What's your homocysteine doing? What's your ApoB? What's your LP little a, right? And that's going to drive the oxidation of LDL, right? So, and make it more impactful and more of a molecular target. And I think Dr. Virchow in the early 1900s or whatever, demonstrated that oxidized LDL is what led to initiating the microangiopathic lesions and endothelial dysfunction. So I'm not an LDL denier, and I don't think it's that misguided. But I do agree with you that maybe LDL itself isn't the culprit, but the oxidation of LDL might be the culprit. Inflammation, oxidation, ischemia, and immune dysfunction. Again, going back to what we said earlier, right? And I also think that I have patients that have cholesterols 275. I could pull up charts all day and show you something. I don't want to break HIPAA, but I've got several people, right, that have cholesterols north of 270, LDLs of 175, HDLs in the 60s to 80s, normal ApoBs, normal LP little a's with coronary artery calcium scores that are negative. Now, I know what cardiologists say. The ACC and AHA recommend, saying, hey, just because the CAC is clear doesn't mean there's no, microangiopathic issues. And that's where I get the LPPLA2, right, the TMAO, and MPO, and all those other biomarkers, right? And then if they can't afford a clearly, for the audience, is basically a CTA, a CT angiogram that's using dye and contrast media and measures hard, soft, and unstable plaque accumulation throughout the coronary vascular system.
Beautiful report. Beautiful piece of work.
Love the report. $1,500, right?
$1,500.
Right. So it's $100 coronary artery calcium score, or $1,500, CTA or clearly heart scan. Depending on where you're at, you have those options, right? I've had both, and I love Clearleys. But if you don't know what the soft plaque accumulation is, you got to be careful, right? And then, not to mention, how do you measure redox potential in somebody? How do we know if there's membrane lipid peroxidation? How do we know if we need to upregulate NRF2 and antioxidant signaling to mitigate some of that oxidation from taking place? How do we know if there's just so much? What is the role of fibrin? Right? We know LP(a) drives coagulation in the system, and that's why you eat the stinky nattokinase, is to break down some of the fibrinogen in the system. And I can tell you now, like when you look at coag as a whole, we have the intrinsic and extrinsic pathway, and that goes through this cycle called coagulation, two different pathways. And like, for example, the intrinsic pathway is characterized by an insult that leads to the factors 12, 11, 9, 8, 10, 5, 2, 1, and then factor 13 to stabilize the fibrinogen. And then, the extrinsic pathway is like a shorter direction towards fibrinogen formation. And again, I've studied this shit. It's ingrained in my brain. 12, 11, 9, 8, 10, 5, 2, 1. I had to memorize coag pathways when I was in undergrad, right? And you would see it under the microscope. Right? So all of these different things lead to microangiopathic issues. What's the role of nitric oxide, right? How many people are walking around with hard, brittle vessels due to a lack of nitric oxide activity in their system? How many people have microangiopathic issues due to lectins, right? Lectins lead to heart disease, right? And again, that's...
Wait, so the nightshade family of food kills us for reals?
So that's, if you were to look at, Stephen Gundry, I think he was an interventional cardiologist or a cardiothoracic surgeon. He revisited some of the work of Peter D'Adamo that looked at, the role of lectins in certain foods, right? And those things microscopically cause red blood cell agglutination. Right? They cause stickiness. I remember identifying this when I was at MD in the blood bank at MD Anderson Cancer Center. To differentiate A1, A2 phenotype, you use a lectin from a bean. It causes cells to stick together. Now, what happens when those cells stick together and they're trying to move through, little small capillaries. What do you think is going to get scraped off? Right? What also happens with high blood pressure and turbulent blood flow? That lack of laminar flow is going to cause microangiopathic lesions. So it's not.
You're singing my song there. I love that part. Yeah.
So and then what's the role of the glycocalyx, right? If the glycocalyx is broken down due to whatever insult, rancid fats, bad things, bad hemodynamics, and all that other stuff, all those variables influence somebody's risk for heart disease. It's not just one, right? Even exercise. Like for me, I think what mediated a lot of my heart disease was I trained jujitsu from high school wrestling. I wasn't good enough for college wrestling, and I didn't want to do that. I was a skinny little 112-pound little Indian dude, just trying to whatever survive. But long story short, like when I trained, dude, I was zone 5. I couldn't breathe. I couldn't talk, right? For years, right? Just that, there's research, I think Dr. O'Keefe out of, I forgot what university, is looking at, high exertional activity and associated with lesions, microangiopathic lesions, heart disease. So your marathon runners and people that are doing high endurance things, that's not good. And I think that's what mediated a lot of my stuff, right? That shear stress against the vascular endothelium. So when you're and again, I'm not a cardiologist. I have studied cardiology, and I think I know enough to have an intelligent conversation with somebody regarding this. That beyond statins and ACE inhibitors and everything else, I see understand the pharmacodynamics and what we're trying to do. But I think it's multifactorial, and we need to start thinking about all the different factors influencing their pathophenotype. Remember what I said earlier. I think our understanding and taxonomy of disease is going to be different for everybody. Everybody has a different flavor of their disease profile, right? It's not just one, right? And I think once we get out of that reductionistic model and just say, oh, all LDL is bad and blah, 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 that we got to look bigger because again, like I've said, I have a ton of patients with really bad dyslipidemia, refuse statins, and have clear arteries. Right. So
that doesn't add up to what we're sold by the pharma narrative, right?
Yeah. And look, Big Pharma is doing their best. I'm not going to say anything negative there just because multiple reasons. Yeah. But, I think they're definitely doing the best that they can faced with the challenges that they have because that's a whole nother podcast,
Yeah. Oh, absolutely true. Doc, this has been the most fascinating. Your depth of knowledge is pretty intense. Wow. On this podcast, we'll put your website below, the therapies. What are some therapies where you can fix something that not many other people can?
So I would say I used to work with Andrew Heyman, who was one of the main guys for American Academy for Anti-Aging Medicine. He's one of the directors there, but he recently left and moved to New Zealand. I exited his practice last year, and we dealt with the sickest of the sick, chronic complex illness. We dealt with a lot of mold, infectious issues, Lyme, co-infection, so forth. And a lot of mold, a lot of CIRS, chronic inflammatory response syndrome. And what intrigued me about that was it was a clear representation of precision medicine. Why? Because we looked at the genetically predisposed with the HLA haplotype. We looked at the transcriptome and identified molecular signatures in RNA that was associated with chronic inflammatory response, whether it was mold, actinomycetes, endotoxin. We saw cell danger response with mitochondrial molecular hypometabolism. We saw dysregulated apoptosis associated with neuronal cell death and just basically nuclear atrophy of different regions of the brain. We mapped it with the brain MRIs. We looked at environmental testing and essentially the home testing. We looked at advanced proteomics, right? TGF beta, MMP9, C4A, VIP, MMP9, all those different biomarkers, and we connect those molecular dots. And when it translated, it was super freaking cool to see. So people that are exposed to mold, genetically predisposed, proteomic, transcriptomic, envirobiomic signatures all tied in. So that was something that I really enjoyed doing, but I got burnt out. It's a very challenging population. I don't have have the tools in my practice to manage that now, so I don't want to, I have a longevity forward practice, right? But I do, want to address hidden threats to our longevity and inflammation. And sometimes, we'll uncover it incidentally, but 25% of the population deal with that issue. And some of the tools that I have here in the practice, we're doing EBU, extracorporeal blood ozonation oxygenation. We pull your blood out, we filter it, we ozonate it, and then we illuminate it and put it back in, giant oil change of the blood. I've got some unique patients within government. I'm here in Maryland that come to the practice on a routine basis to get it done. So it's very interesting. And then, what else are we doing? We're doing some IVs. We're doing Plaque X IVs, the intravascular or intravenous phosphatidylcholine, which, it's interesting to see.
I'd love to measure the before and afters on those.
Yeah, me too. I've got a couple of coming up that are going to have repeat Clearlies after doing the protocol. So we'll see. And then there is, I have the whole longevity gym side of things. We're doing intermittent hypoxic hyperoxic therapy. We're doing hyperbaric oxygen therapy, whole body photobiomodulation, lymphatic mobilization through flow presso, contrast therapy. We do exosomes and stem cells. We do all sorts of stuff. But I take people through this therapeutic order from a longevity perspective. And all this is going to be found in my book, The Longevity Equation, which is going to be out soon. So, I kind of give you that roadmap of like, hey, this is the way you should probably be thinking about it. I'm part of the American Academy of Stem Cell Physicians. It's super.
Well, we didn't even talk about stem. You're doing stem cells too?
Let's say yes.
Okay, just for the audience, the guys who are way into stem cells don't talk about it.
Yeah.
They are so far ahead of the FDA.
Yeah, no.
They don't want to open a door to get their balls clobbered.
Yeah. No, I stay within compliance with all the FDA stuff. Everything I do is above board, right? And because I just got too many things going on, right? And I'm not going to do anything. Some things might not be quote unquote FDA approved, right? But the stem cells we use are FDA registered and linked and follow the new criteria set forth by Florida, right? In regard to chain of processing and minimal manipulation and all the other stuff that are out there for it. So, but yes, you can get stem cells in the US. Is it the same thing as what you're getting at BioAccelerator or, CPI or whatever those places are? They're different, right? It's the world of stem cell medicine is very unique because the thing is, you just don't throw regenerative seeds in a bed of, dead, damaged senescent cells, right? You need to do the gardening first, right? And when you do the gardening first and you nourish the soil, you churn the soil, you're preparing the terrain, you'll be surprised at the regenerative potential when you're using some of these different, regenerative signals, let's just say.
How important is fasting for that gardening?
So I think intermittent fasting is going to address one of the very important hallmarks, which is going to be senescent cell burden and decreased macroautophagy, right, from a longevity perspective. And I think that's going to be very important leading up to this because, as you know, there's a New England Journal of Medicine article, I think in, what year was it, 22? No, I don't remember what year. Not a couple of years ago. It was one of the very few times that New England Journal of Medicine says that 18.6 intermittent fasting is going to reduce your risk for cancer and promote longevity, right? Huge, right? So, I do think intermittent fasting is a very important role in all of this. There's different types of fasting, right? But at the same time, I think, the studies were done mostly on men. So you got to be very specific with age and gender and where you're at in your life. I don't think it's the best for postmenopausal females for certain reasons. And there's a very specific therapeutic order. I'm not saying you can't do it as a postmenopausal female. I think it should be done a little bit more strategically, right? And you need data points to support that narrative, whatever that is, right? So I can't even begin to tell you. We didn't even get into wearables, continuous glucose monitors, and all that stuff, So there's a lot there, man.
No, we did not. We're gonna have to do another one around Christmas time. Dude, thank you for spending an hour. We speed run a lot of medicine right there. And you've got the knowledge base to pull it off, my man. Thanks for coming on. Um,
Yeah, thanks for having me.
we'll put your stuff on the website. I can think of a few patients. There's always patients that you come across that can't solve their own issue, and they just need a new doctor to look at it with a fresh set of eyes. And you got a deep bag of tricks, so hopefully we help it so you can help some people.
Yeah, no, I appreciate it. Thank you.
Word. All right, Doc. Have a good day. Thanks for everything.
Thank you.
All right, bye.
Bye.